Hi, it's Dr. Klingman, Jeff Klingman. I'm chair of neurology at Kaiser Permanente, and I've been asked to speak about expediting stroke transfers. I have no financial disclosures, but I am going to speak about off-label use of TENECTA PLASE for acute stroke. So why is this important about expediting transfers door in, door out, particularly for stroke patients? Well, time matters for clot extraction, just as it does for thrombolytic treatment. There's been studies showing that the faster endovascular therapy, the better outcomes in terms of ambulation, discharge home, and recovery with minimal deficit. So just like it's important to get thrombolytics in quickly, it's also important to give endovascular treatment quickly. So the problem and why this is important is even if you had a perfect field-based diversion program, you're going to miss many patients with large vessel occlusion that may present to the primary stroke center and never get seen by paramedics, because about half the patients with stroke walk in, even patients with large vessel occlusions walk in, and rapid transfer benefits everyone. If they're brought in by paramedics or if they walk in, getting them out the door quickly is going to be beneficial. In our series, a large number of patients, we found that there were a substantial number of folks that actually had relatively low scores on their NIHSS and yet still had a large vessel occlusion. The black line is the cutoff of 11, which is sort of the best place to decide who has a large vessel occlusion, but about a third of patients are less than that, even down as low as a score of 0 for patients, for example, with basilar occlusion. So you're going to miss patients any way you look at it, either by a field-based diversion program or with walk-ins. Furthermore, in a high-functioning system, this was just presented at the International Stroke Conference this year, the RAISE-CAT trial that looked at Catalonia system. They found that there was no improvement in patients that had a field diversion past the closest primary stroke center. And in fact, there was even a trend that in patients that did end up getting thrombolytics, they were actually was a trend that they were and almost reached significance, 0.07, that if you took them to the closest hospital and treated them with thrombolytics and then transferred them, that those patients that ended up with thrombolytics actually almost did a little bit better. So if you have a high functioning system, and that's the caveat, you could make a case that it's really no benefit to taking them to a comprehensive center, but they had door to needle times of 33 minutes at the primary stroke center and 30 minutes at the comprehensive center. And that's pretty important to treat quickly. And then the other thing is they were able to get the patients out of the hospital within 78 minutes median time, which is quite good. In that kind of a system, you do just as well taking patients to the primary center first. So what can you do to expedite door in, door out? Well, we had done published on Stroke Express, which we used to expedite door to needle, but we found that there's a variety of lessons we can learn. One thing you can do is improve your door to needle time. Your door to needle time really should be less than 30 minutes because that gives you more time to treat and transfer. You want to get rapid CT angiogram and interpretation. It should happen right after you treat them with thrombolytics. It's important to do parallel rather than serial processes. And as an example, you can call the ambulance as soon as you suspect the large vessel occlusion, even before you have any imaging. Look at the patient, say this patient has a good chance of having a large vessel occlusion, call the ambulance. You can always call them off. We should do groin prep, Foley placement, sign out to the ambulance while they're en route before they arrive. And you want to eliminate unnecessary steps. There's no reason to burn CDs if you have PACS links, so establishing those with your comprehensive center makes sense. There's really little reason to print a chart anymore because many of the electronic medical records link up. We should have one call to accept at the comprehensive center. If you have to be paging people and calling around, that's going to add time. You should ask to go directly to the angiographic suite, and rather than stopping in the emergency room, that just adds time. And then I think other thing we needed to do with Stroke Express is we picked a pretty aggressive target. And that helps, and you want to pick an aggressive target and really obsess over it. So this is something that you want to measure, and that's what measured gets done. So how do you get to less than 30 minutes? Well, there's a variety of things. I'm not going to go through them, but you can read about them. We published this in January 2018. Stroke, the Helsinki model was what we were based on, and they were able to move to these really rapid times. And so there's a variety of things you can do. And in my opinion, everybody should be able to treat on average in less than 30 minutes, which used to be pretty revolutionary, but I think it's not anymore. At this point, 70% of our cases are currently treated in less than 30 minutes. And then the other problem that we have with transport is where most places we use, if we're using ALTPLACE, you have to use a CCT rig. You have to use critical care transport because of the drip. But a critical care transport is not the right tool for the job. It's really designed for transfer from ICU level care from one ICU to another. It's not really set up particularly for ER transports. When you have a CCT rig, the RN on the rig is going to take ownership of that patient. They feel that they own them, which they do, but that leads to a head-to-toe assessment, extensive sign-outs, when what we really need to do is get the patient to the center where they can get treated. And there's almost inevitably some kind of pump and tubing changeover. So it just adds time, and I've never seen them get out the door in less than 20 minutes. Plus, it's a limited resource. So it takes them, on average, at least 30 minutes to arrive and often longer. So if you do need a CCT, you want to order it early. You want to order it before you get the CTA. You want to do the sign out on route. And we already talked about the preparation on route. So what are alternatives to CCT? Well, one thing you can do is an ALS ambulance, advanced life support, and have one of your local ED nurses jump in the back to monitor the pump. And that works well, except when it doesn't. The problem is we can't always find a nurse willing to go. It may have something to do with staffing. They may not want to work in an unfamiliar environment. So it's just, in my experience, has not been very reliable. It works great when you can make it happen, but a lot of times we can't. And the other option would be basic life support rig, which is done in some countries where the rig brings the patient, waits, the patient gets their evaluation, and that same rig hauls them off to the comprehensive center. Works great, except the problem is that the paramedics and the EMS folks need to be able to manage and monitor that drip. And in California, that requires a special waiver from the state, extra training, and it just hasn't been very successful. There's only one county, I think, in the state that has this waiver at this point. And when we've talked to our local EMS, it's a lot of work, and they haven't necessarily been that interested in doing it. And there's been some legitimate concerns about if the paramedics and EMS people don't do this very often, will they keep up their skills? So the other option is what I call pump-free thrombolysis, which basically is TENECTA PLACE, where there's no pump involved. So TNK and acute stroke, I won't go through this in detail because Dr. Nguyen is going to be talking about it. But the idea is that if you do this, it's one bolus dose and no need for a pump, and therefore no need for critical care transport. Most patients can be transported by BLS. So this has been looked at. It's been reported in Texas. There was a system there that started this about 1.5 years ago, saw substantial benefits in, door out, and all the other metrics as well. We started doing this as well in mid-November, and you can see the red line where we were with door out, and you can see the dramatic improvement on the right side to where we are almost at our target of median 60 minutes. And before we did this, it was about 5% less than 60 minutes. And I wrote 16%, but that was actually before the March numbers. So we've had a significant improvement. And then the other thing is we haven't had a very high hemorrhage rate. At this point, the symptomatic hemorrhage rate is about 1%, and that's in several hundred patients. So what I think this means is that it is doable. You can expedite door in, door out, and it is something that we should all strive to do. Thank you.